Hi there, and welcome to Clinical Laboratory Medicine Throat Swabs. I'm Dr. Alex Alexander, and I can say that the 2-year-old is now taking a nap, so hopefully there won't be a whole lot of screaming going on. Okay, so let's move right into a slide from Epocrates and on rapid tests. And if you don't know Epocrates, you should get to know it. I believe your library has Epocrates available for you, and if you're a licensed provider in the state of Washington, you have access to a lot of really great resources. I'm just now wondering if Epocrates is one of them. I purchased it, so I don't know, and I recommend purchasing it. I think you can get a student subscription for relatively cheap or maybe even free. So Epocrates, fabulous, fabulous, fabulous. Okay, I'm not getting paid by them, but if any Epocrates execs are listening here, I'd love my next 3-year subscription at a discounted rate because I'm pushing your product. So, okay. Rapid antigen detection tests and traditional throat cultures. Immensely helpful in the primary care setting with some caveats. So whereas we said in the last PowerPoint that nasal swabs aren't really going to help you all that much, that is not true for rapid tests. And rapid tests are so easy to do and so easy to get your hands on and so billable, you might as well use them. There's really no reason for you not to have them if you're doing primary care. In fact, I don't know if you're doing anything other than primary care why you might not have them in your office every once in a while. People are going to walk in with a sore throat and you think you're going to treat their back pain, but really they just need something for their sore throat, and you look in there and it looks like strep and you're not really sure, and you send them somewhere else, and then you maybe lost a patient. So you might as well take care of all the people you can. Okay, wait, you just told me in the last PowerPoint I can't be all things to all people. So we'll have a discussion about that in class. Rapid antigen detection tests allow immediate point of care assessment. So that's why I suggest that you get familiar and comfortable using these. And rapid antigen detection tests are 80% sensitive and 95% specific compared with throat culture. And a negative rapid antigen test should be followed by conventional throat culture. So what did I just say? I said if you do a rapid test, then you should always follow it up with a throat culture. Now, you know, in the interest of time and resources and guidelines, I'm also going to tell you that most people are only going to send those negatives that look positive for a culture. So if I rapid strep you in the office and you test positive and you've got all the clinical signs and symptoms, unless you have such severe allergies that it might kill you to give you an antibiotic, then I'm probably just going to treat you well, it's not even presumptively at that point because I have 2 major indicators, my clinical exam and my rapid strep. So then go ahead and follow those negative antigen tests with a conventional throat culture. So anyway, all right, only individuals with at least 3 of the 4 criteria of exudate, adenopathy, fever, or lack of cough should undergo specific microbiologic testing for group A strep, or GAS, it's a gas, Jumping Jack Flash. That was one of the best movies. Whoopi Goldberg. My favorite part is when she's like trying to figure out what the words to Jumping Jack Flash are, and she's in her bunny slippers, and it's all like she's just a bank teller clerk lady, and she's involved in this spy ring or whatever, and she's trying to help get Jack out of wherever he is, and so she's listening to the music through the speakers, and you can't understand what Mick Jagger is saying. Good Lord, you just really can't understand him at all. And she's like beats her head on the speakers, and she's like, "Speak English, Mick." So I really encourage you to watch that whenever you finish watching the last movie. That I think that was My Fair Lady. So My Fair Lady followed by Jumping Jack Flash. Okay. Next slide there. Rapid tests continued. For adults with pharyngitis, laboratory testing is not always indicated. Instead, all patients with pharyngitis should first be screened. So, and what are they going to be screened for? There are those 4 things again. History of fever, lack of cough, tonsillar exudates, which assumes you know what the tonsils look like. And, to be honest with you, you may not yet, but you will soon. Tender anterior cervical adenopathy. And then adults with none or only one of these findings should not be tested or treated for gas, for group A strep. All right, and then how to swab. Well, I've given you a posted video on your Moodle site that I didn't make, so it won't sidetrack you or try to be funny in any way, shape, or form, which shockingly, I don't actually try to be funny. I just sometimes think I'm funny, so you can fast forward over those parts if you can figure out how. So the quick view test, I believe, is the one that I put up on your Moodle site, and it tells you exactly how to swab with the quick view. But here's a nice picture. A picture's worth 1,000 words. Rub the swab across the tonsillar areas in the posterior pharynx, specifically targeting any inflamed areas. So you just want to swab the goo, swab the gross parts. Why swab? Because the stakes are high with certain bacterial infections. The sequelae of strep in certain age population really does compel antibiotic treatment. And I know this class is not about treatment at all, so I'm loath to even say the word, but I'm going to say it: treatment, treatment, treatment. But see Sarah Acosta Smith's lecture notes for what those sequelae are and what age population. Or you can see Family Practice Notebook, Epocrates, any of your favorite books, any references that you want. To swab or not to swab. And this I referenced down here at the bottom of the slide. You can see it's from a 2002 practice guidelines for the diagnosis and management of group A strep pharyngitis, which it's a little old of a reference for me, but it's still extremely relevant today. Patient presentation is sore throat. So you're looking at group A strep pharyngitis, and you're going to be looking to exclude or include that in your diagnosis, and it's clinically predicted by, once again, do you think we want you to know this list? 3 or 4 of the following: pharyngeal exudate, cervical adenopathy, fever, and lack of or absence of cough. And the reason I put absence there is because you're going to see an acronym that I got from the lovely Dr. Pellegrini yesterday in class that will hopefully help you remember this on the next page. It is microbiologically confirmed by a rapid antigen test, and if negative, a throat culture for gas. So, when I was in the military, the things that the instructor would, because we're all not, I can only speak for me, but at least my group, we weren't very smart. So, every time they were trying to teach us something, they would stomp their feet and, really emphasize or highlight or something, this is what you need to know. So if we say it more than 3 times, you really need to know it. And in this case, I think I've said it 3 now: pharyngeal exudate, cervical adenopathy, fever, and lack of or absence of cough. And on the next page there, you're going to see the algorithmic approach. And there is Dr. Pellegrini's acronym, which I understand she may be watching this and saying, I didn't make that up, I didn't make that up. Someone gave it to me, but it's okay, I got it from you, so you get credit for it. FACE, fever, absence of cough, cervical lymph nodes, and exudate. So let's look at the algorithmic approach. Such a pretty little slide there. And if you remember from the basics, the very beginning basic knowledge PowerPoint, voiceover PowerPoint, if you watched it, we talked about all these different kinds of approaches to diagnostics, and algorithmic approach was one of them, and this keeps coming up over and over. Comparison was another one, and keeps coming up over and over. So how are we going to do this? We're going to calculate our risk score. And so what are the points? Temperature greater than 38 degrees Celsius, absence of cough, swollen tender anterior cervical nodes, tonsillar as it is, swelling or exudate, and then there's an age thrown in here. And then this will correlate to what you learned from Dr. Sarah Acosta Smith on sequelae and all that stuff that makes the stakes higher for kids. And then use score to guide treatment. Okay, so it's very simple. Less than 1 or equal to 1, you observe them. Greater than 4, equal to 4, treat them. In the 2 to 3, which is where most of your folks are going to fall, culture, treat if positive. And you can see that came from a 2004 approach to diagnosis and treatment of the patient with a sore throat. And this I pulled straight off of MD Consult because it had a little thing that said I could. Okay, and then the next slide there, I threw it on here because, again, it's our pattern recognition from basics of clinical laboratory diagnosis. And here we go. We have the feature of tonsillar enlargement, tonsillar exudates, tonsillar asymmetry, trismus, love that word, trismus. I can't use it in a sentence, though. Inability to open your jaw. How would I use that in a sentence? I'm going to ponder that. Cervical adenopathy or tender larynx, and for the love of the universe, please do not call it a larynx or a pharynx. It's the larynx. Okay, so if we have tonsillar enlargement, if we have viral pharyngitis, that's usual. The tonsils are usually enlarged. If we have bacterial tonsillitis, it's rare for the tonsils to be enlarged. Isn't that weird? I thought that was weird. Peritonsillar abscess, none, and epiglottitis, none. Okay, this does not make sense to me. I don't like it because I don't believe this should be true. But there it is, and it came from a very reputable source. So it's funny how you don't really think about the things that you don't know when you think you know a lot. So this was really good for me to read this. And I did a little follow-up on it and have some more information if you want that in class. So tonsillar exudates are occasional in viral pharyngitis and mononucleosis, I have in parentheses here. And then bacterial tonsillitis, usual, peritonsillar abscess, often, and epiglottitis, none. And then we go down through here saying that asymmetry is usually present in peritonsillar abscess, and that usually you have trouble opening your jaw. Oh, I could use trismus. Usually you have trismus in peritonsillar abscess, and then usually you're going to have tender cervical adenopathy in bacterial tonsillitis and peritonsillar abscess, and occasionally in viral pharyngitis, but none in epiglottitis. And then your tender larynx is usual in epiglottitis, but rare in viral pharyngitis. None in bacterial tonsillitis and peritonsillar abscess. So I thought that was a really nice pattern recognition. Use it if it works for you, and don't if it doesn't. Next slide there. Isn't that a lovely slide? When to swab. Typical pseudomembrane of diphtheria, pharyngitis. Are we going to swab that puppy? I don't know. What do you think? All right, so guidelines 2012. I've just got to tell you that this class makes me insanely happy, because there's nothing more fun than going through all these great pictures with you. All right, so guidelines 2012, a throat culture for gas is the most sensitive, 90 to 95%, and specific test. And again, we're talking about group A, strep. Recommended only in children at the risk of rheumatic fever. In adults, it's too low to justify routine throat culture. Okay, so we're looking at recommended only in children at the risk of rheumatic fever, that throat culture thing. All right, mononucleosis, again, family practice notebook. It's a clinical syndrome usually caused by Epstein-Barr virus, characterized by fever, pharyngitis, lymphadenopathy, and atypical lymphocytosis in older children and young adults. It's often subclinical in young children. And we have positive heterophile antibody tests and serologic tests for antibodies against EBV that are usually diagnostic. And I'm going to talk about what that means briefly here in a few slides. Rare but potentially life-threatening complications include severe upper airway obstruction, splenic rupture, that's a big one, fulminant hepatitis, another one that you really don't want, encephalitis, don't want that one either, severe thrombocytopenia, I am not interested, and hemolytic anemia, absolutely disinterested in all of those. So we want to treat mono before it gets there. Treatment is usually symptomatic. So heterophile antibody tests for mononucleosis, there are 6 different commercial tests that were looked at in the Family Practice Notebook resource that I was looking at with great references. And the sensitivities range from 81 to 95%, and the specificities range from 98 to 100, so that's pretty doggone good. These tests can be less sensitive in early disease in adults. False negative rates of 25% are found in the first week, but then that drops to 5 to 10% in the second and third week. Nearly 10% of adult patients with infectious mono will be persistently heterophile antibody negative. So they actually have it and they're negative. This test may also be negative in children under 4. False positive tests are possible. Yes, let me buy my false positive test, please. False positive tests are possible in patients with autoimmune diseases, cytomegalovirus, toxoplasmosis, rubella, and lymphoma. I don't know if you guys have had your infectious disease class yet, so I don't know if you know what some of these are, but anyway, you can certainly ask me in class. False positive test is also possible in patients with acute retroviral syndrome from an early HIV infection. So what are we doing here? We're using the Monospot. There's really no hyphen in it. I don't know why I thought I needed to put a hyphen in there. Heterophile antibody test, the Monospot, and the efficacy is 95% sensitivity and specificity. False negatives for the Monospot, as we said, are early, common early in the course. And so week 1, 25% of your people are going to be false negative. In week 2, 5 to 10. And then week 3, it drops to about 5%, from 5 to 10% false negative. It's not a throat swab. So why is it here? Well, because you're going to DDX mono and strep sometimes. So Monospot latex is the test that I have a picture here. And you can see the 3 little circles and the little vials, the little plastic vials of stuff. And I just went on Amazon.com just for fun, and 50 tests cost you about $300, so $287. So it's a relatively inexpensive test. So $300 for 50 tests. I can't do the math fast enough, but I know that it is relatively inexpensive, $6 or so, right? 6 times 5 is 30, so with tax, we're looking at about your cost about $6 per test kit. The test relies on the agglutination, and I'm sure you get it much less. Oh, I don't know. I was going to say I'm sure you get it much less expensive from your rep, but I actually don't think that's true anymore. The test relies on the agglutination of the horse red blood cell. And there are others besides horse, but horse just happens to be, well, for one, let's just start with the most awesome. And for two, it is more sensitive and specific than the sheep and the bovine. So the test relies on the agglutination of the horse red blood cells by heterophile antibodies in the patient's serum. And a heterophile in this context basically means it reacts with proteins across species. Oh, a really great movie, Species. Oh, okay. Heterophile also can mean that it's an antibody test or an antibody that reacts with antigens other than the antigen that stimulated it. So an antibody that can cross-react, or an antibody that cross-reacts. So chew on that for a second while we move on to what labs to do on whom and why. Labs. So I've highlighted in a nice, lovely purple color for you there what's relevant to our particular place in the world right now, because I don't really want to get you too confused. But if we look at this family practice notebook, cut and paste, we will see that labs for pharyngitis, throat culture, followed by lymphocyte predominance, lymphocyte atypia. So those are blood tests, right? Never let monkeys eat bananas. There's the L. Heterophile antibody test, the Monospot. We're talking about that right here, right now. And then number 5 is the antibodies to the Epstein-Barr virus antigens. And that would be, again, something you would not likely do in your office unless you have a lab in your office that's certified and all that kind of stuff. So what labs for you to do on whom and why? Today, all we've taught you, we being Dr. Sarah Kosa-Smith, myself, Dr. Lambden, and Dr. Mueller, and I really can't even say what Dr. Mueller taught you because I don't even know her yet. Hi, Dr. Mueller, if you're listening to this. Throat culture and heterophile antibody tests, that's what we're doing. So when we get into the next couple of weeks, we'll talk about lymphocyte predominance and lymphocyte atypia, and then our antibodies to the EBV antigens. But you'll see there that the throat culture excludes coexisting strep pharyngitis, and concurrent strep pharyngitis incident is 4 to 30%. And then you can see if we're going to test people with a pharyngitis for monospot as well, with the monospot as well, then we're 95% sensitive and specific. I think I beat that horse to death. Revisit pharyngitis again from Family Practice Notebook. Points number 2, 3, 4, 5, 6, and 7 could potentially relate to our throat swabs. And we look there at streptococcal rapid antigen test. And we look at a pure throat culture, which we would send away. We wouldn't get a rapid test on that. And then there's our monospot, which isn't a throat swab at all, but it is dealing with the throat. And then once again, our heterophile antibody test. And then we could do fluorescent antibody for diphtheria. I don't know why I highlighted that, but I'm not going to re-record the entire video. And then we could also look at fungal cultures if we were really excited about figuring out what's going on. Or we could look at a gonorrhea culture. But I got to tell you, by the time it gets beyond that, I'm also in the mood to consider a referral. So unless I'm specializing in something other than primary care, then I'm probably not going to be going that deeply into where I need to do fungal cultures and gonorrhea cultures on throats. I mean, a gonorrhea culture wouldn't be that unusual, but personally, this is just a personal preference. I will do pharyngitis for Epstein-Barr for mononucleosis, and I will do a rapid strep. But other than that, if the patient's negative for both of those, presumptive treatment doesn't get them better, it's looking like signs and symptoms, history, all that kind of stuff is taking me down a different path that's out of my comfort zone, it is not my best moment for me to decide to treat a patient outside my comfort zone. It might be in my scope of practice, but again, this is something that I want to model for you guys. You don't have to make it true for you. Nothing I say ever has to be true for you. But if you figure out what you're good at and you stick with that and you do it really, really well, then you will have a very successful long practice with lots and lots of patients. On the off chance that you need to do everything for everybody, then of course you're going to get excellent at doing all of this stuff, and that would be great. And then you can come back and teach me. All right, some fun pics. We got strep throat there. And then we have a nice mononucleosis picture. And I couldn't really decide how to spell woe. I'm not sure that's right, but I went with it. And then there is a beefy red. What do you think that is? It's pretty commonly known as a strep throat. And then the last slide there, comparison, bacterial versus non-bacterial. I just like that picture. Okay, so bacterial, come to the health center, whatever that means to you. And non-bacterial viral, monitor at home, gargle with salt water. So we're talking about red swollen tonsils and throat redness on both. We got a gray furry tongue on one side, the bacterial side, and we got a swollen uvula and whitish spots. So that is the go to the health center picture. All right, and finally, do rapid test for strep and mono. Do not assume that the rapid test is really negative if clinical signs suggest otherwise. Do send negatives for culture. Do not delay treatment in the red flag categories while you await culture. Thank you so much. Have a lovely rest of your day.